Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. So in this episode today, I am going to talk one more operative surgery. This is one of the commonly performed general surgical operation, namely the hemorrhoidectomy. So these are not actual real surgeries. I'll be discussing the various steps of these procedures using a diagram and the actual intra-op pictures. So this you can use as a mental rehearsal before actually going to perform these surgeries in real life. So before going to perform these surgeries, if you go through this video, which consists of the various steps of this particular hemorrhoidectomy, so you will become very confident in performing these procedures, and this will be very useful for the surgical trainees. So under hemorrhoidectomy, I am going to talk about actually 4 different procedures for hemorrhoids. One is Barron's banding, another one is the hemorrhoidectomy, both open and closed method. The open method is known as Milligan and Morgan's open hemorrhoidectomy. The closed method is called Ferguson's closed hemorrhoidectomy. I am also going to these two Barron's banding and hemorrhoidectomy is age-old procedures, whereas the staple hemorrhoidectomy and the ultrasound guided hemorrhoidal arterial ligation are the recent advances or the recent procedures for hemorrhoidectomy. So I will be talking about all these 4 procedures one by one. The staple hemorrhoidectomy is also known as PPH, that is procedure for prolapsed hemorrhoids. Likewise, the ultrasound guided hemorrhoidal arterial ligation is also known as THD, that is Transanal Hemorrhoidal Dearterialisation. So coming to the Barron's banding, what are the indications? You can perform Barron's banding for first or second degree hemorrhoids only. Anesthesia, there is no need to give anesthesia. However, if your patient is very anxious, you can give conscious sedation. You can do it as daycare office procedure. You can do it in your surgical OPD itself. Position, you can put the patient in left lateral position, that is Sims position, or you can keep them in lithotomy position. So this diagram is showing this is the internal hemorrhoids which originate above the dentate line, which is insensate. There is no sensation. Even if you are going to cut this, patient won't feel the pain. Whereas this is the external hemorrhoids. Okay, this is always below the dentate line. You can see this. This is the 4 degrees of hemorrhoids or 4 stages of hemorrhoids. In first degree, okay, the internal hemorrhoids, it won't protrude outside. In second degree, okay, the internal hemorrhoid will protrude outside, but it will get reduced. Whereas in third degree, okay, this will get protruded outside, but it needs manual reduction. You have to manually reduce it, otherwise it won't get reduced. In fourth degree hemorrhoids, okay, there is prolapse, but even manually you cannot reduce it. That is fourth degree hemorrhoids. So coming to the Barron's banding, this is the gun you can use for the Barron's banding. What you have to do this tip, you have to you have to join the tip with this applicator. This is the applicator, and this is the band. This is the rubber band. So this is very small. You have to put it here, and then you have to push it over up to here. Okay, you have to load 2 bands. This is usually black in color. So 2 bands you have to load here. After loading it, you can unscrew this loading part of the this gun. You can unscrew it, and then using a grasper, you can put it inside. Here you can see you have to put a proctoscope. Through the proctoscope, you put this gun inside, and through this you have to put the grasper, grasp the internal hemorrhoids, and bring this gun very near to the hemorrhoids, and then you have to go snugly. You have to touch that hemorrhoids. This hemorrhoid should go inside this gun, and then you can fire it. When you are firing it, okay, both these rubber bands will slip, and it will snugly fit into the bottom of this hemorrhoidal plexus. This is what you are seeing. 2 rubber bands we have applied with the help of this Barron's banding gun. This is what you have to do. Because of this one, what will happen? This part of the hemorrhoidal plexus will get necrosis. The blood supply will be cut off. This will fall off because it will undergo necrosis and it will fall off. So that is the mechanism. So nowadays there is another thing called space bender by one ConMed medical company. So they have manufacturing this space bender. This also you can use just like the variceal banding. Here, apart from just putting this thing, we are using the vacuum for sucking this hemorrhoidal plexus. So this is the bender. You can apply it either facing upwards if the hemorrhoid is situating in the upper side, or facing downwards if the hemorrhoid is in the lower part of the rectum. So you have to apply it like this, and then you can attach this syringe to this area here. This area you can attach the syringe. You can suck so that a vacuum will be created, and the hemorrhoidal plexus will be sucked in like the esophageal variceal banding. Almost the same mechanism, but here we are using the syringe to create the vacuum. So after sucking in the hemorrhoidal plexus, you can push this star bolster. This star bolster you can push it in so that the outer blue tube will glide over the inner white tube, so that this band, this black color white band, will slip into the bottom of this hemorrhoidal plexus. So this is what you are seeing here. So they have pushed in that one. Okay, it is applied to the bottom of this hemorrhoidal plexus. Then you can unscrew this one, and there is another bystand rubber band is there. If this rubber band is not applied properly, or if you want to apply 2 bands, okay, again you can reapply, again you can attach the syringe, and then you can do the same thing. But you have to slip it to this white tube before pushing this star bolster. You have to push this rubber band to this white tube, the inner white tube, and then you have to repeat the whole procedure. So this is the space bender. Here is open hemorrhoidectomy. So the indications are 3rd degree hemorrhoids, or hemorrhoids with other anal pathology like fissure or fistula. Here you can give either GA or spinal anesthesia, or epidural, or even you can use local anesthesia. The position of the patient, either prone jackknife position, or you can use lithotomy position. So informed consent you have to get after explaining the risk of the surgery. So what are all the risks or complications? After the surgery, some of these patients, 1% of your patients can develop injury to the anal sphincter, resulting in anal or fecal incontinence. Rebleeding can occur in 1% of the patient. whereas anal stenosis also can occur in 1% of the patient. Coming to the pre-op preparation, you should do colonoscopy to exclude any proximal colonic pathology in all your, hemorrhoid patients. You have to give enema on the evening before and on the day of surgery. You have to give enema twice. So position, I told you already, either the prone jackknife position. This is the prone jackknife position, and this is the lithotomy position. And then after putting the patient in either of these positions, you have to do what is called triangle of exposure. That is, you have to catch the mucocutaneous junction at 3, 7 and 11 o'clock position. This mucocutaneous junction you have to catch with the hemostat, and then you have to retract it laterally so that the internal hemorrhoidal plexus will be exposed at 3, 7 and 11 o'clock position usually. Then the internal hemorrhoidal plexus also, one by one, you have to catch with another hemostat. You can use the curved artery forceps, you can use to catch the internal hemorrhoidal masses. This is what you are seeing here. After that, the next step is you can hold both these artery forceps. You can hold it in your palm. You can put your right hand or inside the anal canal and give a lateral push here. Use the other hand and you can take a scissors, which is a blunt nose scissors, and you can make a V cut in the skin here. So you have to make a cut here, and then slowly you have to dissect off this hemorrhoidal plexus from the underlying internal and external anal sphincter. The internal anal sphincter, you can see it as a white layer, whereas the external sphincter, which is deep, which is pink in color. So you should not injure either of these sphincters. You have to be very, very careful. What I usually do, I wrap a dry gauze over my index finger, and I will pull this one, this hemorrhoidal plexus, I will pull this side, and with the wrapped gauze piece over my index finger, I will push this tissue away from this area so that this is a blunt dissection. If there is any hemorrhage there, you can control it with cautery. That you can do it. So now after dissecting of this one, this will be hanging only by that pedicle, but that hemorrhoidal pedicle, there shouldn't be any muscle here. So you should not injure both the internal and the external sphincters. So the next step is you have to put a transfixation suture over all the 3 vascular pedicles with either 2O vicryl or 3O vicryl you can use. You can do a transfixation suture, but the knot should go inside the lumen here. So after putting this transfixation suture, you can cut off this hemorrhoidal plexus, this redundant part of the hemorrhoidal plexus, you can cut it with the scissors. So you can repeat the same thing. Here they have already excised, here also they have excised, this also you have to excise. This is the same thing, the transfixation suture you are seeing here in this picture. So after finishing your surgery, the area should look like this. So there will be 3 raw areas, and in between you have to see clear skin areas. The normal skin should be there. The 3 the areas should be there in between these raw areas. So if the appearance is, it looks like a clover, the trouble is over. Suppose if it looks like a dahlia, it is definitely the surgery is a failure. So you have to be very careful. There should be skin bridge between these raw areas, 3 skin bridges. So you can trim this raw area also. You can trim if there is any bleeding. Okay, you can achieve the hemostasis by using a cautery. So you can do, this is what I have explained is open hemorrhoidectomy. The same thing we can do what is called closed hemorrhoidectomy. This is known as Ferguson's closed hemorrhoidectomy. So now directly you can clamp the only the internal hemorrhoidal cushion you have to clamp with the curved artery forceps, and then you have to make a elliptical incision on both sides. But before that, you can inject a local anesthetic here. You have to start the incision from the mucosa towards the skin. You have to start it. Now you are seeing here, you can use a scalpel. You can start the incision from the mucosa to the outside skin. So this is also the same thing. You have to do it, and then here you are seeing the same hemorrhoidal plexus. You have to dissect off from the underlying. This is the internal sphincter and this is the external sphincter. The deep lying external sphincter is pink in color. The superficial sphincter is white in color. So after dissecting off this hemorrhoidal plexus from the underlying sphincter muscles, you have to put the same transfixation suture over the pedicle, and then you have to excise this part. So after excising this hemorrhoidal, the plexus, you will be having this raw area. Here, unlike the previous open hemorrhoidectomy, we have to close this mucosal part. You have to close, but you need not close the skin part. Skin part you can keep it open so that any collection inside will drain through this one. So this is what is called close hemorrhoidectomy, Ferguson's close hemorrhoidectomy. So instead of using these sutures and scissors and all, nowadays they are using a ligature, this instrument. This also you can use. See here, you are seeing the internal hemorrhoidal plexus. This is the external skin. You can use directly the ligature, dissect off this hemorrhoidal plexus from the underlying skin, and then you can seal the pedicle, vascular pedicle, with this ligature. The vascular pedicle, there is no need to put any sutures here if you are using ligature, or even you can use harmonic scalpel. The complications and post-op care for hemorrhoidectomy, the complications are the following things. That is, number one is stricture or stenosis. You shouldn't excise more than 3 hemorrhoids at one operative setting. Removal of excessive anal tissue may lead to stricture. So I've told you already, there should be enough skin bridges in between. If there is not enough skin bridges in between, okay, the patient will go for anal stenosis or anal stricture. You have to ensure in cases of rectal bleeding that other sources of GI bleeding such as colonic cancer and diverticular disease are excluded before doing hemorrhoidectomy. Bleeding is another complication. If it is severe and persistent, that need to be controlled in the operation theatre. Anal incontinence is another complication, especially if you injure the sphincter complex during the dissection of hemorrhoids. Hepatic cirrhosis with portal hypertension and other bleeding disorders should be thoroughly corrected before doing this procedure. Otherwise, you can cancel the procedure. You shouldn't do the procedure unless you have controlled the portal hypertension. You have to control that. Usually, we won't do surgery in a patient who is having portal hypertension. Coming to the post-op care, you can use sitz bath. Daily, you have to give twice a day. After each bowel movement, you can ask the patient to sit on a sitz bath. Then you can do digital rectal exam at discharge and after 1 week time to prevent adhesion between the raw area in the anal area, raw areas around the anus. You can use anal pack. This is surgeon's preference. I usually keep non-adherent sponge to tamponade these blood vessels at least for few hours. 5 to 6 hours I used to keep. Then I will pull it out. You can use local application of lignocaine jelly to reduce the pain, or you can give oral analgesic tablets as needed. You must give mild oral laxatives for 2 to 3 weeks during the post-op period. Patients can be mobilized immediately after surgery. You can give 1 week rest or 1 week off from their regular work after hemorrhoidectomy. Procedure is staple hemorrhoidectomy. So here you are seeing the instrument. It consists of an anal dilator with obturator, the pursing speculum, the thread puller, and this is the stapling gun. The same thing you are seeing here also. The stapling gun, this is the obturator, and this is the anal dilator, this is the pursing speculum, and this is the thread puller. So what you have to do, you have to place the patient in the lithotomy position or in the Sims position. Then you can introduce the anal dilator fully inside along with the obturator. So you have to dilate it so that the hemorrhoidal, internal hemorrhoidal plexus will be pushed inside. This is what you are seeing. This is the internal hemorrhoid plexus. This will be pushed inside. Then you can remove the obturator outside. This is what you are seeing here. This white thing is the obturator, and this is the anal dilator. This is the anal dilator. So after removing the obturator, you can fix the anal dilator to the perineal skin with stitches. There is 4 slots in this anal dilator. Through that you can fix it to the perineal skin. So the next thing is you have to apply the pursing suture. So you can apply this pursing speculum inside and taking a needle holder with a needle, you can suture it all around the mucosa. So you have to take a bite, a pursing suture well above the dentate line, 2 to 3 centimeters above the dentate line. You have to take the all around. You have to take, and this bite should not be far away. So it should be very near bites. You have to take all around. You have to take. This is what you are seeing. This is a diagrammatic picture. This is the actual surgery you are seeing, and this is the pursing speculum. So they are taking the bite all around above the dentate line. You have to take it. So after taking this bite, okay, you can see it like this. So it will come like that. Then you have to try to oppose this, pull it in opposite direction, put your finger inside and see whether it is gripping your finger adequately. That you can check. So after that, now you have to take the gun, the hemorrhoidal, the stapler you have to take. So what you have to do, you have to open this stapler. For that you have to rotate this knob anti-clockwise so that the anvil will separate from this chamber of this stapler. So there should be at least 2 to 3 centimeter gap between the anvil and this chamber in the stapler. So then you have to introduce it through this anal dilator inside the anal canal, and this anvil should go above this the suture, the pursing suture. It should go well above the pursing suture. That you have to make sure. And this box, this stapler gun, there will be markings 4 centimeter. The whole 4 centimeter of this, this stapler should go inside the anal cavity. So after introducing it properly, okay, this is what you are seeing here. We are introducing it, but usually there is a safety lock here. So you have to unlock this only when you are going to fire it. Otherwise, even accidentally, you cannot fire this gun. There is a safety lock here. So that then after that, okay, you have to ligate this thread, this pursing suture thread. You have to ligate it snugly over this anvil axis. Over this anvil axis, you have to tightly. You have to close it. Then you have to take it out, and then you have to take it through that slot. For that, you have to use this thread puller. You have to put through this slot and catch hold of this thread, and you have to pull it through that slot, both sides. Both sides you have to pull it through the slots. Then you have to pull it so that what will happen, this excessive or redundant mucosa will come and lie inside the chamber. While you are taking the bite, when you are taking the pursing suture, you have to take the bite only the mucosa and the submucosa. You should not take the bite. You shouldn't, involve the underlying muscle you should not take. That is the most important thing in this stapler hemorrhoidectomy. Especially if it is a female patient, you should not include the posterior vaginal wall also. This is the two things, common complications of staple hemorrhoidectomy. You should not take the bite, you shouldn't involve the muscle also. Otherwise, while you are doing the stapler, you will be cutting the muscle also. That is not, that will produce a lot of problems. So you have to take the bite only very superficially. So then you have to close it. For closing, you have to rotate the knob clockwise. So that what will happen, the distance between the anvil and the chamber in the stapler will be, will be lessened. The distance will be less. So the anvil will lie just above the this box in the stapler. Now the whole 4 centimeter of this box has gone inside the thing. Now the anvil and this box is just lying just nearby. So now what you have to do, now you can release this safety lock and then you can fire the gun. You can fire the stapler. What will happen now, you can see a marking here, this orange mark, which will be in this side to begin with. When you are firing the gun, the orange knob will go to this end. Okay, and then after firing, you have to keep it like that for 30 seconds to maybe 40 seconds. Okay, then what you have to do, you have to turn, you have to unlock the gun by rotating it one turn, 3/4 of the turn or one turn. You have to do it, and then you can remove the gun along with the anal dilator also. The stitches you can remove both together. You can remove it outside. So when you are taking it outside, you can unlock it further. You can unlock the anvil, and then inside you can see a clear cut downut. This is not only a mucosal downut. You shouldn't see any muscle in this downut. Inside you will be seeing, this is the mucosal, excessive mucosal part has been cut by this stapler. You can see this staple line you are seeing here. Again you have to introduce that pulsing suture speculum. You can introduce inside. Look for any staple line hemorrhage or bleeding. If there are any bleeding, you can suture locally. You can suture there so that the bleeding will stop. The only precaution here is the bite you shouldn't take very deep to include the muscle. You have to take only superficial bite. In case of female patient, you have to be very careful. You shouldn't include the posterior vaginal wall. These are the two precautions you have to take while you are doing staple hemorrhoidectomy. So after the surgery, you can put a pack, non-adherent pack, or a spongiston. This is the spongiston. You can keep it for some time, and after that you can remove it. Procedure for hemorrhoid is ultrasound guided hemorrhoidal artery ligation, or THD, that is transanal hemorrhoidal dearterialization. So this is the equipment, almost like our pulsing suture speculum. So here inside the speculum you can introduce the artery forceps along with the needle, and here is the Doppler probe. This is the Doppler probe. This you can slide. This is a sliding component, and this is the Doppler ultrasound beam. You can pass it there and you can pick up. This is the artery, the hemorrhoidal artery. You can pick up because you will get a audio signal. If you are putting the Doppler ultrasound beam there, you can get a signal like beep, 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 like that. Okay, then you will be knowing that you have picked up the artery. So this is a pivot. You have to push the needle holder into the pivot, and then you have to rotate it so that you can suture ligate this artery. This is what they are doing. This is the various steps of this procedure. So you have to introduce this instrument inside. With the help of the ultrasound probe, you will be able to pick up the artery, and then with this needle holder and the needle, you can suture ligate this artery, the hemorrhoidal artery. So there are other the other steps I will be showing in the next video. Yeah, here. This is the equipment. This is the THD equipment introducing the gadget inside the henna canal. Lithotomy position only. You have to identify the hemorrhoidal artery with the help of the Doppler probe. This is the Doppler probe. This is the Doppler beam you are seeing here. And this is the hemorrhoidal artery. You can get that audio signal. So what you have to do, with the help of this needle holder and the needle, you can just, first thing is you have to identify the artery, and then you have to ligate this artery. First one bite or one ligature, here one more ligature you have to put. Ligate the artery, securely you have to ligate. Two ligature you have to put in this hemorrhoidal artery. And after ligating the artery, you have to use the same ligature. You have to take multiple bites in the mucosa alone, and then you have to tie it so that the mucosa will be elevated. So it was redundant. After putting all these sutures, some 3 to 4 sutures, this side of the, see, compare the mucosa this side. So hemorrhoidal plexus is here, whereas this hemorrhoid is elevated because of these sutures. So after putting this one, you can cut off these sutures. Again, you have to put back the instrument inside this side. No need to put the artery forceps. Using the Doppler probe, you have to send the beam proximal to the ligature where you can get the audio signal. Then slowly you can withdraw this equipment. You go below that or distal to that ligature of the artery. Now if you send the beam, there won't be any audio signal because you have already ligated that artery. The supplying artery to this hemorrhoidal plexus we have ligated. That you have to confirm it by doing the Doppler probe proximal as well as distal to this ligature. You have to confirm this. So thank you very much for watching this video. If you think that these videos are very helpful, kindly subscribe to this channel and share these videos in your social media. Thank you once again for watching this video. Let us meet in yet another video. Until then, bye bye.